receive a survey at the end of the session. Your opinion matters to us. Please take the time to complete it. Thanks for your attention. Tonight, I have the pleasure to introduce our guest speaker, Dr. Davin Lim. Dr. Davin Lim is a dermatologist based in Australia with extensive expertise in aesthetic medicine. He's the founder and director of Cutis Dermatology, and the Melasma Clinic is a renowned expert in energy-based device. He's an international speaker at leading medical congresses and a trainer and mentor to physicians worldwide. He has authored over 20 peer-reviewed articles, and he has received awards and recognition from professional medical associations such as the American Academy of Dermatology, the British Association of Dermatology, and the Royal Society. It is a pleasure tonight to welcome Dr. Davin Lim in his practice.
Thank you very much for the, Sandra, thank you very much for the kind introduction. Guys, I'm going to do a presentation today on Derma V. It's going to be a very candid presentation, and let's see whether we can get this started. These are my associations, and let's get on with the slide. So, vascular conditions are super common. They account for between 15 to 30% of dermatological practices. One thing to bear in mind that I practice in Australia, and approximately 85% of my patients are skin type 1 and skin type 2. The remaining 15% are obviously higher skin types. So you have that in bearing when I give this presentation. It's very important that when we're using vascular lasers, we understand our skin type, because obviously with the competitive chromophore of melanin, one has to be very mindful when we're using energy-based devices. Now, how I try to give this lecture is that in life we compare everything. We compare cars, whether it be American cars, your Japanese cars, your Korean cars. We compare things like appliances, fridges, and even televisions. So tonight, what I'm going to do is going to candidly say I'm going to compare these devices. And we own all of these devices. We own 3 V-beams, the primer, as well as 2 perfectors, because for those of you who know the primers, probably you do need a couple of perfector lasers there just in case. We also own the XLV and the Derma V. So in this lecture, I'm going to compare and contrast and give you merits of each of these devices and tell you the pros and cons truthfully. Now, Derma V itself is a vascular laser. It's created as a vascular laser. However, with the dual wavelengths of 532 and 1064, it can have effects on pigment as well. So the conceptualization of the Derma V is this: to have both the V-beam and XLV benefits in the one device. To treat pigment and vascular conditions, it's got to be fast, ergonomic, and reliable, stable, and important, and it's got to be battery down. All of these devices, the whole idea V-beams, the prime, both something like the stable XLV, where you're using a solid state KTP, but also use something called the ICD, or integrated cooling device, which is also known as DCD, which is dynamic cooling, which goes hand in hand with the Candela devices. So as a background, Lutronic had 5 years of R&D using the competitor's device. So when you look at the history of how vascular lasers evolved, sure as day, we know that the Candela was the first one that started back in the late 1980s. It had a really good revamp, I think, in mid-2000s or 2004 with the V-beam Perfector. The Perfector is still a laser which we use today, and we prefer that compared to the newer ones, which is the primer. When you look at the reiterations of the third generation vascular devices, that's in the 2019, 2020, you've got the reiteration of the XLV in the primer with its 2 wavelengths of 595 and 1064. So of all these vascular lasers, the Derma V is the newest. Now, when you're looking at the ultimate dermatology platform for vascular, you need this. You need power, obviously, because you need the correct fluence. You need depth, because we need to get to the vessels itself. You have both superficial and deep. You need the wavelength as well, because that dictates the obviously the depth, but also the wavelength also dictates your chromophore competition. You need safety, and obviously we need speed. So this is the ideal platform. This is the wish list of which we all want. And it needs to have a really broad breadth of applications, which means it has to be appealing to dermatologists, has to be appealing to physicians, nurses, and also easy to use and easy to understand for our junior therapists. And ideally, you should have indications both to treat medical and cosmetic conditions. So everything from things like your birthmarks, your port wine stains, your vascular lesions, and the common things, for example, like your rosacea, your acne scarring, toning and tightening when it comes to aesthetic users, as well as your poikiloderma sevata, as well as your dyschromia. So what's the right wavelength? And if you guys heard me lecture on the Pico devices, it's really converse to this. For Pico devices, for example, like, if we're using a 755 wavelength, we want to have it as a standalone, whereby we're targeting melanin with very little hemoglobin competition. But for this, if you want a laser which can do a little bit of red, a little bit of brown, the 532 wavelength is better than the 595. The 595, sure, it has a better selection for hemoglobin over melanin. However, in this context, we're using the 532. So you get competition with the melanin, which can be promising and which can also be useful, but also, as you will hear me say later, you've got to use that with caution. And it's purely based upon selective photothermolysis and chromophores. So when we look at the penetration depth that we should have a laser which can penetrate both, you can treat superficial but also deep. So obviously with the longer wavelengths, you get a deeper depth of penetration, while something like the 532, though the depth of penetration is not as deep as something like the 595, that can certainly compensate with something called forward scattering. And forward scattering is basically this: if you use a larger spot size within reason, and if you get the sufficient fluence with the larger spot size, so remember that you need the sufficient fluence with it, you can get deeper penetration. So this is how we get very equivalent depth of penetration to the 595. And if you want to look at deeper vessels, so certainly things like your periorbital blue veins and your mixed AV malformation, certainly the 1064 is the way to go, and the blebs as well associated with port wine stains and venous lakes, etc. One thing the Derma V has is the variable spot size with also the IntelliTrack and temperature sensor. So this is a very automated, like I said, it's a fourth generation device. So unlike your V-beams, this can track, so your overlaps are exact. And also the speed can be controlled, and also has a temperature sensor, which is very handy, especially if you're using the 1064 in the what Kutira calls the laser genesis, but we use a different name for that. Okay, so the most important thing as well is fluence, and with any vascular laser, if you increase your spot size, you have to have the fluence that matches, because there's no point increasing the spot size with fluence that doesn't match. As a comparison, if we're using things like the primer, we all know that with a V-beam perfecta, and once again, this is not to say I don't use the V-beam lasers. When we know that the V-beam lasers, they have a sweet spot at around 10 mil. Certainly, the newer ones can go increase spot size, but for those in the know, we know that the fluence actually drops. And even the old V-beam perfecta even's got a 12 mil. Most of us max out on the 10. So it's important to have sufficient fluence. This I know because we use these devices day in and day out, so we know the shortcomings of each company. Effective skin cooling. This is something I always practice and I always preach, because with effective skin cooling, you really decrease the amount of discomfort for the patient, you increase the safety levels for the patient as well, the comfort levels, and you make your life much more efficient because you're not using coupling gel. So ICD is the old-fashioned term for, or it's a new-fashioned term for DCD, which is basically cryogenic cooling. Many advantages. If you work with gel coupling devices where you need conduction using a sapphire window, you'll know that there are many things that can go wrong. With your ICD or DCD, it's a fire and forget system. All you need to do is check that it's on. By default, it's on. Sometimes we need to turn it off, for example, when we're using the 1064 big spot. But in the majority of times, we always leave it on. So by default, it's on. Now, when it's on, you don't need to check because it's automatic. When you're using a coupling system, we have to check each time because you've got to make sure that the cooling is on, the plate is cold, your gel is adequate, the flotation of your device has got to be accurate, so you're not pressing too much, so your coupling gel has got to be of the right amount. So there are many different variables, but with this, it's a fire and forget, which means there's lots of things. There's many things that can go wrong with the coupling, but very little that goes with ICD. Because if you can't, if it's empty, if the canister empty, you can't actually physically fire it. So how it works is basically the chilling of the skin. So you pre-chill during the procedure as well, and after as well. So that's the actual process when you're looking through an IR or an infrared camera. Now, when we talk about the correct pulse width, obviously you have to vary the pulse width based upon the diameter of the vessels itself. This can mimic the older fashioned first generation and second generation V-beam devices by what's known as a pulse train. So basically you're splitting the pulses within the pulse itself. So you can have a sub microsecond pulse mode, you can have a sub milli where it's a little bit longer with the pulse duration, or you can have the single pulse as well. And why is this important? Basically you're treating vessels of different sizes. So my colleague and mentor, good friend, Professor Phil Becker, has taught me that when you look at vessels, when even things like a port wine stain, you use a dermatoscope, because when you look closely, conventional thinking states that you may have one vessel size, but no, you actually have many different vessel sizes. So by having a variable pulse duration, you can treat vessels of different sizes, and that's based upon your selective photothermolysis. So speed is very important, right, when we're treating patients. So now, if we're comparing the pulse dye laser to Derma V on the port wine stain, let's see whether this plays. The hertz rate, and this is super treating. This is the older generation E-beam vector. The max hertz, as you guys know, is between 1 to 1.5. 1.5 is maximum. That's on the good day if your pulse dye kit is fresh and the laser's not playing up. So you're looking at between 1 to 1.5 hertz. That's maximum. Now, when we're comparing the pulse dye laser to Derma V, watch how fast this is. So this video is borrowed from my colleagues who killed us. So it
kind of shows you if you kind of miss one area too. Mm-hmm.
Yes.
So you can see with that, it's a super quick procedure itself. In fact, when you're doing vascular treatments, you have to recalibrate your entire brain because it goes so quick. It's got easily within an adequate spot size together with fluence to do anywhere between 4 to 6 hertz. But even when you use at 3 hertz, it's super quick. And with the IntelliTrack system, your overlaps are perfect, absolutely perfect. So gone are the days where you have to manually, I guess, figure out how to do a 20% overlap, because this one does it for you. Clinical outcomes, so port wine stains. Some of these are my slides, and a lot of these are from overseas as well. So it provides a non-purpuric solution. When you look at this initial study, and all the studies reflect this, we're looking at the obviously the gold standard, which is your pulse dye laser. When you look at this, the pulse dye laser, which is your V-beam perfecta, is your number 3 on the spot. Now, when you look at all the comparisons, it's important to realize that when we promote this laser for the use in port wine stains in anywhere between skin type 1 to skin type 3, we do not get a superior outcome when it comes to resolution of the port wine stain. And I think we observe that as well. But what we have is non-inferiority. So basically, it is very similar to the end result that you get with your pulse dye laser, but with a few caveats, which I will discuss shortly. So these are the expected outcomes, and it's very reproducible in that skin type. I think this is Roy Geronimus. So basically, when you look at these slides, you go, "Oh, there's not much in it." It's true because we're using different spot sizes between 8 to 12 mils. But when you really look at the fluence variation, it's very small compared to you guys who are used to using, for example, your pulse dye laser, where you can decrease your pulse duration, for example, even halve it or even quarter your pulse duration, and have big spikes when it comes to fluences. With this, it's less forgiving. So when we use on-card settings, which I encourage everyone to use, and you inch it up gradually, so there's no big changes in fluence nor your pulse duration. But what we do change is the difference between your sub-milli, single, and sub-micro pulse trains. So what we have is that it provides a less purpuric solution. So we're not looking at the endpoint, which we're so used to with our pulse dye laser, where you're looking at immediate purpura, immediate or persistent purpura. This, you get this unnerving graying, but that's your endpoint. And what's good about this is that your recovery is quicker. Your clearance rates are very similar, but your recovery are quicker. So this is Sue Kilmer's photographs from the US in regards to port wine stains and vascular work in treating mature purpura as well, and that's Roy Geronimus. So this is one of my patients who was resistant to V-beam. I used the Derma V 532, and we got this within, I think, about 2 or 3 sessions. So this is a very superficial vascular birthmark, and it's easily cleared with this. So no problems at all in lighter skin types with this. Sue Kilmer's case when it comes to clearing port wine stains in younger infants. This is a very good paper. I had the chance to meet Lydia Nguyen from Germany. She's a dermatologist, and a very pivotal paper, which I think is very truthful as well. It shows compatible clearance compared to your pulse dye laser, so non-inferiority. But the 532 KTP, which is the Derma V, has less downtime. And as we know with most pulse dye lasers, the malfunctioning of your PDL, because it's an unstable system compared to your solid state KTP, your PDL malfunctions a lot. So in their study, when they looked at all the time frame of all the pulse dye lasers, including the V-beam, the Synergy, which is your 585, together with your vascular, the malfunction a total of 6.6 months for the entire study, while the Derma V malfunction 0. So that's a very good and accurate representation of things. So just to summarize, when it comes to Derma V compared to pulse dye lasers, it's a non-purpuric, less downtime solution favoring the Derma V. It's got more applications. There's no dye costs, which is huge because your dye kit costs, every year add up. We pay up to $18,000 a year just to run our pulse dye laser. I'm not joking. That's $18,000 a year. In over, a good 5 years, you basically have to buy a new system. It's faster than your pulse dye laser, and it's also more ergonomic. So when do I use a pulse dye laser? It's this, and once again, this is not due to the laser itself. This is just due to that that chromophore chart and the chart on your competition between your melanin and your hemoglobin. So when we're really pushing it for darker skin types, so when I'm talking about darker skin types, you're darker Asians, so when I'm really pushing the boundary, I do think that the pulse dye laser, purely based upon this chart, once again based upon physics, probably gives you a little bit more safety margin compared to your 532. Once again, it's purely based upon the absorption chart here itself. So for darker skin types, when I'm pushing it, I still favor the pulse dye laser. The 532 makes short work of angiomas, pretty standard treatment using the 532, usually resolves in 1, maximum of 2 sessions. Erythema, I usually mix the 532 together with a 1064 for erythema as well. Vascular rosacea is the same thing. Most of the time it's 532. Certainly if you have deeper vessels or vessels which are larger caliber, especially your perialar, that's when you use your 1064. And it's a very, very fast system to interchange between the 2 wavelengths. Vascular rosacea as well, nasal vessels, facial vessels as well, using different wavelengths. So it gives you the flexibility of using the 532 for more diffuse erythema and using your 1064 in the tracing setting for deeper, more resistant vessels as well. Venous lakes, super easy. Predictability 80-90% with one session. So this is one of my patients, quite a large venous lakes, and this is 2 sessions. I find it really good for mixed AV malformation. So one where you need a longer pulse duration, but you also, and using the 1064 because I need to go deep, but also use high affluence, long PD. So I couldn't get this using the other systems, but this is a mixed AV malformation we just treated a couple of months ago. So I tried it with obviously the 595 and in the 532, not applicable in this situation. The 755, we did have some improvement in the 755, but when I switched her to the 1064, we got some good clearances. This is just one session itself. And this is my cheese. I love treating periorbital blue veins. In fact, some days I'll treat 2 or 3. I love it because it's got a very high predictive rate of clearance. So with periorbital blue veins, you only need 1 session in over 90% of the time using your 1064. I angle it obviously away from the orbit, use skin cooling, use a longer pulse duration, and in the majority of times we get clearance just in 1 session. So I tell the patients maximum to 90% of the time we get them in 1. And with these patients, you are quite surprised because it really is life-changing for them. They've got these visible veins for many years, especially in lighter skin types. In darker skin types, not too much of a problem, but in lighter skin types, it's with the translucent skin, certainly it can be a cosmetic treatment as well, significant because of cosmesis. We'll see whether we can get some video. I don't think the video came on this. Yeah, so basically it's just 1 session, safe and effective in all skin types. It's highly predictable, and to me, it's one of the most satisfying treatments I do on a day-to-day basis. So you can see how exciting dermatologists are when we get excited about treating veins like this. So let's see whether we get some. Okay, aesthetic dermatology. What other applications can we use? Oh, this is, I think, that video showing the how quick it is just using the 1064. With a spot size of somewhere between 5 to 7 mil. Aesthetic dermatology, what do we treat with this? We can treat poikiloderma of Savart. So these are often very resistant to your vascular lasers, but we can use the 532. If there's any brown, we can pick up the brown as well. And with your poikiloderma, one thing that's good is got the IntelliTrack system. So in the past, when we were using vascular lasers such as the V-beam, we usually max out on the 10 mil spot size. And we all know that when we're treating using the vascular lasers, we can get checkerboarding. So your checkerboarding is less with this, and your spacing is a lot better because we try to do anywhere between 18 to 22% overlap. and it's super quick. It's probably about 6 times quicker than your V-beam. So how does it compare with IPL and BBL? We'll see whether we've got some video with this. Let's see whether it plays. You can see the large oxide in the internal tracking as well. This keeps tracking the pulse and make sure the overlaps are unlike
Okay, I'm done. Okay, just a little bit.
So that's one of my favored devices for treating chest décolletage area as well. And what it has as well is the real-time temperature monitoring as well, which can pick up your temperature, and we try to get it not past between 42 to 44 degrees. So let's move on. Sorry, this one. So for décolletage, because you're using the 532, we're going to get some pickup with your hemoglobin, and you can see they're using the infrared. We can get a real-time temperature monitoring of what's going on during the treatments. So moving on, décolletage area can be treated using the 532. Usually a series of treatments, I say between 3 to 4 sessions. Very forgiving from skin type 1 to skin type 3. Obviously with tanning, you've got to modify your settings, and when you're trying to push it in darker skin types, when you're trying to clear the décolletage, it may not be the best option. Possibly the pico lasers are probably your better options for the darker skin types. Hands in lighter skin types using your 532, it's very efficient in treating hands as well. Bruises, to be fair, when it comes to treating bruises, just about any vascular laser can do it using your 532. You can use your 532, your 595, 585. A lot of the bruises will go with within 1 or 2 sessions. So instead of having a bruise for 7 days, you decrease the duration to 2 to 3 days with bruises as well. Vascular melasma. There are lots of publications on vascular melasma using everything from 532, 595, yellow light lasers, 810 diodes. I personally find it very tricky. You know, I can't, I guess, replicate what the publications show, even though I'm doing the right settings and pressing the right buttons. I think that vascular melasma is hard to treat. You know, I particularly prefer your plasminogen modulators and your VEG1 modifiers or inhibitors as in your T-acid orally. But certainly if you want to use a vascular laser, you can use that, but be very careful with your thermal overload with vascular melasma. Your skin cooling's got to be exact. So with vascular melasma, what I do is that if I were to attempt it, I often pre-chill the skin using an ice pack. I treat it. I never use the Pico nor the Q-switch devices on the same during the same day. I've tried doing that in the past, and the rate of melasma flare-ups is very high. So with vascular melasma, you've really got to follow your on-card settings, pre-chill the skin, post-chill the skin, and obviously use your topical corticosteroids as well, and be very careful about not giving an increased thermal load during the procedure itself. So really good before and afters from some of our KOLs in Asia. But like I said, I personally find this a very tricky condition to treat using any vascular lasers. Acne and acne scars, you can use your 532 to treat it. It works in a couple of ways. Number one, you do have a slight peak of your porphyrin. Your porphyrins are actually, your peaks are in your 410, 420, as well as your next peak around the 630, 633. But you do have a little bit of uptake in your 532. But how it works is it reduces your, not only your C. acnes count by using your oxidation from your porphyrins generated by your C. acnes, but also modifying the environment as well, and decreasing your cytokines and your leukotrienes and all the inflammatory markers. So that helps with acne as well. I like using the 1064 for acne scarring because I think that decreases your erythema as well, but also remodels your skin. So let's see whether the video plays. We'll go with this. Once again, using the IntelliTac system, so we call this IntelliTone. We're using a big spot size in somewhere around 800 to 1200 shots. Very similar to your laser genesis settings. And that basically also reduces your inflammation, provides some heating between 42 to 44 degrees on the skin. That also stimulates some collagen in remodel scars as well. Tightening, I think that this is a brilliant laser for not really correction, right? But I do think it's good for prevention. There's a difference between correction and prevention. I think that using your 1064 in that setting can increase the collagen contraction, but provides very low level biostimulation. So, if I can give you an idea about your so-called lifting, especially for the newer cosmetic physicians and dermatologists and plastics in this lecture, we think about things in different layers, right? So, all the way from bone, all the way up to your layer 1, which is your skin. So with your 1064, it's really heating layer 1. You do get some small amount of heating in layer 2 in your subcuticular area, but the heating is very limited. So when you think about tightening, we think about biostimulation, right? Whether it be stimulation using your injectables, whether it be stimulation using your high energy devices, whether it be your CO2 lasers or your RFM, or even things like your HIFU. So where does this all play in? I think when we're talking about skin tightening, I often try to tighten in different layers. So it's just not one thing. It's not just your collagen stimulating injectable. It's not just your laser. It's not just your HIFU. It's not just your RF or your RFM. I think that we provide different avenues of collagen stimulation, whether it be through your generation of your heat shock protein, immediate collagen contraction, using your different devices, or whether it be your foreign body reaction using your, whatever, your PLLAs or your CAHAs or your PCLs. We're trying to actually give your skin different avenues to generate collagen at different layers. So I don't believe it's just one device, and I often employ this as part of the momentum. In other words, the big push, and the big push could be whatever you want, whether it be your injectables, your energy-based devices, but the smaller pushes at regular intervals just make sense. Like when you're trying to push a door, a heavy glass door, you give this big push, which is your initial push, and then you carry forth the momentum. And how I carry forth the momentum is with this device, where it has smaller pushes but at regular intervals for the patient. It's more cost effective for the patient in the long run as well, and they probably get a better result with all this. And how do we do it? We do this with the IntelliTone mode, which is your, Katira's old-fashioned way of laser genesis, using a big spot size, high rep rate, and just heating the dermis. So there's a couple of here I am getting this treatment. So I get the girls to draw it in vectors. And we use the 1064 large spot size, firing anywhere between 800 to in a small area up to 1400 shots. It's a very, very comfortable treatment. And with this, it's really good because when you look at your other devices with consumables, this has no consumables. So I rate the 1064 really highly on this with this, and this is the same system that we use, or the same method as what Cyanosure uses for your 5D lifting with their device. So I really think the 1064 comes into play. It's one of my favorite wavelengths, vascular wavelengths as well, for the no downtime. A lot of these slides are from Asia, from my colleagues. And just remember, obviously, when you're practicing in Asia, you have different dermal contractility. Their collagen contracts a lot easier. They get immediate collagen contracting a lot easier compared to the lighter skin types. So just apply that according to your population. And with your elastosis, if you think what it looks histologically, you have fragmented collagen in the dermis. We're not going to contract fragmented collagen. So with your lighter skin types, types just know the limitations of your long pulse Nd:YAG lasers. But for the Asian population with good preservation of collagen and a very high reactivity rate with very brisk fibroblast reactions, certainly this sort of low downtime, no downtime treatment can be very good. So if you are after energy-based devices, you can replace some of these, not a lot of these, because I still think like your ultrasound, like your HIFU and all are very, very highly focused and very powerful. You know, I think things like your BBL, your IPL, all of that provides IR heating, whether it be your BBL Forever Young, as well as all the other fluffy stuff. A lot of that can be replaced with the large spot size IntelliTone settings of your Derma V. So in summary, I think this is a good vascular laser. I highly rate it when it comes to a vascular laser. I use it more. So once again, I use it more than the pulse dye laser in my practice, with the caveat that if I'm treating darker skin types and I'm really pushing it, where I have to use a short pulse duration, I still would favor the pulse dye lasers. That's why we keep the pulse dye lasers in the practice. But for the majority of patients, the 532, especially in lighter skin types, are better, far faster compared to your pulse dye lasers as well. And a couple of the other small details, one of the inventors of this, one of the engineers, is a friend of mine, James Bartholomew's, and he's really made a really big difference when it comes to the ergonomics, everything from the handpiece changes to even how the laser operates and all. So kudos to a well-engineered device. And that's all for now. So more than happy to answer some questions there, Sandra.
Thanks, Dr. Davin Lim, for this informative presentation on how you use Derma V in your practice. You know, as we know, we can treat at least 55 indications, and you gave us a good idea on how you can use it. Look, we have really, really great questions. I'm going to start, you know, with one. Sorry, I'll try to push it to the screen. Okay, it's going to come. Sorry for the delay. Let's try the other one. Oh, we go. Push a slide. Here we go. Sorry. In your experience, what strategies help minimize swelling in rosacea patients treated with Derma V? How do you typically manage the expectation before and after treatment?
Right. I think you know, sometimes it's the simple things which make a lot of difference. So for me, it's automatic pilot. Every time I do a vascular, I always give ice, and my straightforward, like I say this probably about 6 times a day, ice 5 minutes on per hour every hour until you go to sleep tonight, quick little showers. And then if you're waking up tomorrow, it's a little bit swollen, ice 5 minutes an hour every hour. So basically, I'll give them 2 ice packs. I put it on. Every hour, they just apply it for 5-10 minutes. Sleep with your bed slightly inclined. If they swell up the next day, ice. As dermatologists, sometimes we know that even simple things like doxycycline is an anti-inflammatory, especially if they have florid rosacea, papulopustular rosacea. So it's your combination between, you know, your laser energy-based devices and also medical. I think that probably gives you the most amount of reduction when it comes to swelling as well. Antihistamines, I don't think works. You know, and most of us don't give antihistamines. You have a big rip-roaring reaction. And for patients who've had this before, we just give a short, sharp dose of pred, maybe 50 milligrams on the day and 50 milligrams the next, and taper down to 25 milligrams the next. So swelling, I think, is less compared to the pulse dye laser. Certainly your TIP, your transient intermittent purpura, is much less compared to yours. Remember, your endpoints are totally different when it comes to. So for those of you who are used to using your pulse dye laser when you're looking at particular endpoints, don't chase that endpoint using a 532. You'll run in trouble. You know, with the pulse dye laser, and Sandra, you and I have worked for about 15 years together, so we know that we can, if we go, oh, cool, if someone doesn't respond on a 6 millisecond, we can drop the PD in half and do it in 3 milliseconds. Can't do that with this. Follow the guidelines. It's not a pulse dye laser. If you try to push it, you're going to get in trouble. So manage your expectations before and after treatment. I think in Australia, I guess with our Medicare rebate system, we do get, I can't remember, I think about 4 treatments per calendar year. So I say, look, I'm expected to get it under control within 4 sessions. I try to push it and try to get under control within two to 3. But when you're asking this question about expectations, all the other things count. Your flare-up factors would be simple as things like, your quick cool showers, your application of your sunscreen, a reduction of flare factors. Those are equally as important compared to your spot-on dialing of your fluences and your settings.
Thanks a lot. That's really helpful. That's a bit oh, I don't know, that's one pushed. Okay, how many sessions do you typically find necessary to achieve significant clearance on common lesions like facial telangiectasia? Do you use a 2-pass technique for resistant telangiectasia? Look, as we know, with different devices, we use obviously different protocol. The audience is interested about your treatment practice.
Yeah, so once again, it really depends on, I think isolated, just empirically and just looking, isolated tellies are much easier to clear compared to tellies on a background of significant flushing, blushing, and erythema. The way I look at it is you've got small vessels feeding the big vessels, and you've got someone who's very vasoactive. So if you have isolated tellies, usually it's a good sign that you only need, one treatment will give a significant clearance. But obviously with this, you tell the patients up to 3 sessions, but most of the time you get a significant clearance in 1 or 2. The ones which are harder are the ones with your diffuse erythema in the background, and you've got your isolated tellies as well. And then the ones which are harder still are your deeper ones, your larger caliber ones, and that's when you might use your 1064 for that. And do I use a 2-pass technique? Yes, I do. In fact, even when you're using for example, other vascular lasers, you might want to use 3 passes, sometimes even 4 passes. But yeah, 2 passes I think are fine.
And how do you approach the second pass? Do you use exactly the same settings, or do you change your pulse duration?
I think the rule of thumb is that you try to change so it depends. If it's a larger vessel, you increase your pulse duration. If it's smaller and you're treating a smaller, more diffuse, you decrease your pulse duration. But generally, we try to use the minimum amount of energy. So I tend to go for, within reason of the diameter size itself, a shorter pulse duration compared to increasing the fluence. I might increase the fluence later on, but your PD drops first. So we all, like everything we do, we want to get the minimum amount of energy to get to the end point or the end result, rather than actually pushing the energies up.
We have another topic you started to talk about. If you have a mix of linear vessel and global blushing, what do you treat first? That's a common question. Do you treat the linear vessel or do you the global blushing?
I treat, so often I treat both in the same day. I'll trace the linear with the 3x10 or small spot size and actually trace it. And then after that, treat the diffuse erythema. I think one of the downsides is that if you got, especially if it's like, my eyesight's getting bad. So especially when you got glasses and then you put your laser goggles on top of that, and then when you hit your diffuse erythema, right, vessels makes it really hard to see. So my logic is that if I can't see it, I'm not going to treat it. So I actually treat the standout vessels first, and then I'll use the second pass, use erythema. Purely
Thanks for that. Another question.
Because I can see it a lot better with the first pass.
Thanks a lot. I'm just going to push another question. And that's again a question on small vessel to close that chapter. When treating small facial vessel, how do you determine whether to use some macros or milli settings? As we know, with the Derma V, we have all this capability, of variable pulses. If some milli is used but the vessel persists, would it be appropriate to follow up with some micro in the same area?
Yeah, I mean, so the answer is yes. If the vessel still persists, I would change the pulse duration and the pulse train before I actually increase the fluence. You do have a little bit of leeway, so I guess when you're more comfortable with the device, so my standard protocol for everyone using this is follow your on-card settings, and when you're comfortable, gradually increase your fluence. Obviously, if the vessel size is larger diameter, you might increase your pulse duration as well. So yes, I do play around with these different settings based upon the vessel size. It's either decrease or increase based upon the size of the vessel itself. Is this what it says? It says, what are your tips for treating vascular indications in darker skin types?
Interesting questions. What are your tips for treating vascular indication in darker skin types?
I think this is something where all of us know that especially operators of your pulsar laser is more forgiving, right? So with this, not that you can't treat darker skin types, you got to be on card settings with it, which Carl Cheng taught me and said you've got to be very careful with your cooling, that you don't give too much epidermal cooling. You have too little epidermal cooling, and obviously that can be bad. You have too much epidermal cooling, and that can lead to PIH as well. So I think that sort of stuff, I probably think that Carl's got more insight, especially when it comes to really pushing it, because I know he treats a lot of darker skin types compared to what I do. He likes to go slightly less compared to your on-card settings with your ICD. I spoke to him a couple of months ago, and I think darker skin types follow your on-card settings, right? Follow your on-card settings. If you're trying to treat, my advice is if you're going to try to push it on skin type 5, you can get away with skin type 5 with your pulsar laser. I probably wouldn't be game enough to do this on, skin type 4+ or darker. So this is where I say, even for me, my brave pills, I won't swallow that. I'll defer to a different wavelength. So once again, it's not your device, it's your wavelength which counts when it comes to darker skin types. Have you got any other questions there, Sandra?
Oh, yeah. One, and your point is a good point with this. Yeah, I'm just trying to push that one, and it's really on the same topic. Some difficulty going for it. For some reason, it doesn't want to go through, and that's a really good topic too. I'm going to stop that slide, but it's a good point when it comes to Chile. Buenas tardes. It's a really good point. I think the one with the DCD, your RCD, on the darker skin type. Cooling can also create PIH. And presentation. Yep. I've been using this wonderful equipment for 6 months, and however, I have 3 skin type for patients with rosacea who develop PIH, metal spot size, some millisecond 10 ms, 5 joule, ICD 15, 15, 10. What do you think might have been the error?
It could be a couple of things. I think as physicians, first of all, we try our best not to blame ourselves nor the device, right? So every time I get a side effect with the patient, and if I know my device well and if I know my settings well, I interrogate the patient. And in the majority of times, if you know your settings, most of the time it's not you, it's not the device, it's the patient. So first thing I look about obviously is your is whether they've had a lot of sun exposure after that, right? Because that can contribute to PIH. I do think what you said, like what I reiterated, is your excess cryogen. I think Carl was going to revise some of the guidelines for treating darker skin types with probably less cryogen compared to what the on-card settings are. When I'm looking at this, the fluence is fine, the spot size is good, your pulse duration is fine. So these are all on-card settings. But I think it's probably the DCD we might need to revise and review.
I love using Intelliton with 1064 for collagen stimulation in my Latin American patient. In this type of patient, can excessive heat slightly worsen their melasma? Do you have any consideration when treating this type of patient? For example, using a little Zima, additional cooling.
Yeah. I mean, that's a good point. When you're treating the genesis for melasma, I guess there's a couple of things. Number one, you may decrease the vessels, the deeper vessels, certainly the superficial vessels. You have your 1064 epidermal bypass. So you may not get the superficial vessels, but you may get the deeper vessels. So that's one of the things, is we can reduce that. I like your logic as well, because using the 1064, we know it provides very low-level collagen stimulation. And as you know, when it comes to melasma, one of the etiological factors is your cellular senescence. So if we can strengthen the basement membrane and provide some kind of neocollagenesis, we may alter the crosstalk between the fibroblasts, your endothelial cells, your keratinocytes, your melanocytes, your mast cells, and so forth. So I think what you're doing when it comes to collagen stimulation to treat the dermal senescent side of melasma is logical. When you ask me about heat, yes. When you look at the action spectrum of melasma, you'll know that's UVB, UVA, visible light, all the way up to your IR. So your heat can cause it, can flare it up as well. So we know that. We know that we need to get between 42 to 44 skin temperature before this treatment is effective. So it's much of a catch-22 situation. What I do is I pre-warn the patients, no matter what you're using, whether you're using your thulium lasers, your HIFU, your RF, 1064, you all generate heat. I mean, that's a matter of fact. Even when you're doing pico, I'm doing a paper at the moment when we're using high hertz pico, even though it's photoacoustic, when you actually move very slow, your thermal load actually is significant. Not even significant, actually increases between 2 to 3.5 degrees per spot. So I think you're in a catch-22 situation. You tell the patient basically is that, hey, I'm looking at a long-term improvement in melasma. What I'm doing now is to remodel your dermis. You've got a slight chance that the heat itself may flare it, but you still need, unlike when you're picoing or doing pigment lasers, you have the ability to move quick. This one, you need that endpoint of your 42 to 44. So you can't be too quick, because when you're too quick, at the end of the day, you're not going to get that thermal load, which is what you're trying to do here. And then if you cool it with ice, that's the same thing. It's a hard thing. You basically tell the patient you may flare it up, you get them informed consent, and you do it. The other thing as well is maybe use less of that and think of other ways to remodel the dermis without causing heat, things like your collagen stimulating injectables and so forth. But this is a hard catch-22 because your action spectrum is in the infrared.
Thanks a lot. We had a few questions about periorbital veins treatment.
Yeah.
Okay, I'm gonna.
Yeah.
Okay, I'm gonna. What kind of setting do you use?
Oh man, I've got so many different settings. Okay, first of all, on-card settings are very, very good. I use between a 5 to 7 mil spot size. Don't because I go through so many different frigging devices. I haven't got this. I use between 150 to 160 joules between 20 to between around 30 millisecond, maybe even a bit longer for the pulse duration. But the on-card settings are there. And same with your venous lakes as well. The on-card settings are there. Your venous lakes, I use a lower fluence. Your periorbital veins, I use slightly higher fluence, but all within the actual therapeutic range of which the on-card settings are. The great thing about the Derma V, I know it sounds bad that I don't memorize these treatments. A lot of the time, you just press that button. I get kind of lazy. It's like your, the different settings in your car. Once you actually preset, you just press it. And then when I press it, I check it, and I'm bad with phone numbers. I can't even remember my own phone number and trying to remember these. But those are the rough numbers.
And we had also a question around side effects treating in that region, around the eyes region. Any side effect or consideration or complication?
I guess the main side effect on this. Yeah. I guess the one thing you don't want to do is hit someone in the eyeball. Your 1064 goes really deep, yeah? So if you're going to go anywhere near there, you're going to have the internal eye shields. The other thing as well is you can have eye injury, especially if the patients roll their shields upwards. So I always hold the actual shield down and then fire away. So the most important thing, obviously, is your ocular injury. Anything on the lids, if you're doing anything on the lids, you have to have intraocular eye shields. If you're doing stuff on the margin, if you fire away, pull the actual skin down, cup the lid up, ask them to look up as you fire, but angle it away. That's very important. When you're using the 1064, and there's a lot of stuff in the literature in regards to your necrosis of, for example, your alar artery in the groove. That's been reported. And that's something we're always scared about. But Phil Becker, my good friend, says that, and he's done more than any derm, I reckon. He's never had a case, and he's not really worried about that, especially if you use sensible parameters and you don't pulse stack in that area. So certainly occlusion of your arteries has been reported. But in actual fact, I think it's extremely slim. Your ocular eye injury is probably more important.
Question more around the swelling. You know? I mean, as we know, vascular laser tend to, lead to some and ask about swelling. What do you think about the
So I'm not worried. I just give them ice, and in the worst case, I say you may swell up, maybe a little bit red for 2-3 days. That's fine. What do you think, doxycycline versus prednisone? Prednisone is better, but you obviously don't want to give prednisone to everyone because of your risk factor of avascular necrosis. So as derms, we're very mindful that, hey, if you prescribe, you can prescribe it for the odd patient if they've got exaggerated swelling. I prefer doxycycline because it's far safer. Your prednisone is far more effective. But once again, as derms, we're always aware of avascular necrosis with even stat doses of prednisone.
We had also question about, and I think you answer, about choosing between some milli and some macro, information on how do you select?
I think I go by the on-card.
Or do you choose some milli or some macro?
Yeah, I go with the on-card settings, and if it doesn't respond, I mean, it's an easy way to cop out, and so if it doesn't respond, I flip over to the other. So I think the on-card settings are really good. And I'll tell Sandra, as you know, with lasers, right? If you look at most companies and most devices, when we give on-card settings, generally speaking, it's very conservative. When you look at your picos, and even when it comes to your candela, when we're treating vascular lesions, it was so conservative. One thing I'll say with Lutronic, I think Sue Kilmer, who wrote a lot of these protocols 4 or 5 years ago, and Roy Geronimus, Sue is in this very spot on. So when you get your on-card settings, don't think it's another laser and start chucking in, 40-50% high fluences. Follow that. So when you're asking me about sub-milli or sub-micro, follow the on-card settings, and then if it doesn't respond, flip to the other. Don't alter your fluences by a big margin. Just inch it up slowly. I think they've dialed it in.
I totally agree with you.
Yeah.
They're really great settings, and you don't want to push it. That's for sure.
Yeah.
No, that's an interesting question, about PDT and the use of laser.
To activate it?
For PDT?
Yeah. So, I think I just published a review on
the
it.
Derma V 532 nanometer.
Yeah. So I just published a review on it maybe 3 years ago or so in one of the Australian journals. And yeah, certainly using your energy-based devices. And like I said, the peak preference 420. Traditionally we use the 633, 630, 633, the two peaks over there. But you do have a little peak around your 530 activated, yes, and you can activate it using your 595 as well. Just be aware that because you're dumping a lot more fluence, even though your peak absorption is less, it hurts. So you activate it very quickly, and yeah, it stings a tiny bit.
Overall, is it less painful than the usual PT, like putting under the light?
Yeah, I guess it depends because the light norm traditionally, if you're using your 37, yeah, because your light, if you're using it at 37 joules per centimeter squared, I think you're still cooking for about about 7-8 minutes. And if you use a lower fluence, then you might be over longer. So yeah, I think it's much of a muchness because you get that short, sharp pain, but then you've got a really long, prolonged cooking when you're using a lower fluence. Yeah. And some of us used to treat the vessels at the same time. So, we kill two birds in one stone because you've got your actinopaths with a lot of vasculature as well. So we use your vascular laser to activate the porphyrins, but also treat the erythema. Try to kill two birds in one stone.
And I have the last question, probably. As
vascular,
we can see currents.
Yeah, I guess.
What are your suggestions to prevent it?
I guess there's two things. If there's lesions that are going to happen because they're going to happen. Spider nevi, for example. You tell the patient it may recur, but most of the time when you get it, you get that spot. That doesn't mean they won't have more. So your Campbell and Morgan spots, your spider nevi, your venous lakes. These are all lesions which someone has got a genetic predisposition to get them. So very rarely you get recurrence of that lesion, but you get new sprouting out. So you don't usually have a recurrence per se. Obviously stuff like your venous lakes where you're partially treated, then you might get it. Your periorbital blue veins, they get many years remission with that. So it's often many years remission. When it comes to vascular recurrence for rosacea, as you know, they probably all recur, right? So you can treat your tellies, you clear them and even your actinic tellies, you're going to clear them for a while, and then they're going to recur back. And obviously with your rosacea, you got to guide them in regards to your flare factors. But just say, I tell the patients this can all recur. And there may be small things that you can do that modify your lifestyle changes that may decrease the amount of inflammation in the skin, that may decrease the redness. But yeah, it's hard. They do recur. It's good.
And I have sorry?
So I just say, fortunately, not that I think about it. It's funny because my partner will say, when you treat a condition that recurs, for example, melasma, it's a good business model because they'll always be back. So.
No, of course, with vessels, it can be tricky, as you mentioned. You treat an area, and of course, from the patient point of view, they think, it's recurring, but maybe, the area you've been treating.
Yeah.
Lim. As we know, some people develop blue-purple veins on the lower face. Do you then the peri-orbital one? They're usually not raised. They're obviously more flat, on the lower face.
Yeah, they're smaller, they're more superficial. Sometimes you can get them with the 532, sometimes you can get them with the 595. Rarely do you need to use a 1064, and most of the time you don't need to use longer pulse duration because they're very small vessels. So that they're different setting compared to your they usually occur around here. You stretch it, usually young females. So they're different setting compared to your periorbital blue veins. Like you say, they're flatter, they're more superficial, they're smaller vessels compared to your periorbital blue.
So would you suggest to use smaller spot size?
Yeah, smaller spot size. Yeah, a 3x10 head. It's often you just do the 3x10. And like I said, you can try with the 5 and 1064, they're a little bit deeper, or you can go to a 3mm spot size.
Thanks a lot. I think we went through, and the audience was really engaging. Thanks so much, Dr. Davin Lim, for this informative webinar. It's always a pleasure to collaborate. And that concludes our Q&A questions, of course. And for the audience, you can use the same link if you wish to rewatch this webinar. You can do it. And I really, really want to thank you for your attendance. All the attendees are still online, which is a really good turnout, And I want to thank again Dr. Davin Lim, and I wish you a good evening and see you soon. Thanks a lot.
Thank you. Bye-bye.
Bye-bye.